Good evening, dear all Pure Urology Facebook viewers. Today we have our special speaker, Dr. Kashinatham sir, who is going to speak on freehand technique in ultrasound guided punctures. So we have sir with us, and I'm going to introduce sir, and then I'll hand over to him. Dr. Kashinatham sir is a consultant urologist, andrologist, and transplant surgeon in Yashoda Hospitals. He has done MCH Urology from SWIMS Tirupati. He specializes in endourology and laparoscopic surgeries. He has performed over 500 kidney transplant surgeries. And he has done workshop on the study of metabolic evaluation of urolithiasis, role of laparoscopy in aberrant renal anatomy, single stage repair of hypospadias, laparoscopic management of urinary tract calculi, etc. And he has won gold medal in microbiology, and he was the best outgoing student of the year 1999. And he has also won the gold medal at AP Sogas 2018 Warangal chapter. So over to you, sir. How you developed interest in this ultrasound guidance usage, and how you got interest in this freehand technique especially. So please elaborate, sir, and then you can take over your presentation.
Am I audible?
Yes, sir.
Yes. Thank you. First of all, thank you for inviting me for this Zoom meeting discussion. Actually, everyone, as a urologist, everyone is very much comfortable with fluoroguided puncture. But a situation comes, some of the situations like where you cannot have a CM proper images, like do you have any obstruction or completely ureteric stricture, where you cannot do RGP in these patients, and especially patients who have sick patients like empysematous pyelonephritis, pyonephrosis, all these patients, you must need to have the ultrasound guided technique to puncture the system. Because every time we are not that much in a comfortable position to get a good RGP and puncture the system according to the test tube. These are the situations where we need compulsory ultrasound guided imaging. So during COVID time, when we have less number of cases, that time, actually we have started doing ultrasound punctures 15 years back before itself, when we are doing in MCH also. We have learned this technique when we went for a 15 days course for Nadiad, where they regularly doing ultrasound guided puncture in the side room, not in the main OT, for pyonephrosis and putting stents, emergency cases. They regularly doing. So then when we have seen that their technique there, then we came back to our institute and we have started. We have an ESW machine where it has an ultrasound attached. Regularly we are doing CN guided ESW only. But once we are seeing there is ultrasound there, we have used that ultrasound for doing punctures. So initially we are not at all confident during PCNL punctures. So what we have done with that ultrasound, we used to put PCN first. Then after 1 or 2 days, we used to do PCNL through the same track. In that way, we have slowly started learning ultrasound. Then again, when we came to practice also, we used to go to radiologist with ultrasound room every time. We used to discuss with radiologist, and we used to do PCN. What we have done in SWIMS, here also in private practice, we used to do puncture in ultrasound suite. Because initial period of time, there is no ultrasound in the OT. So many of the all the urologists have the same problem. We don't have ultrasound, how to do puncture like that. But luckily, as anesthesia, people are regularly using ultrasound, and vascular surgeons, they are regularly using ultrasound. Slowly, ultrasound machine has come to our OT. Then we have started using that ultrasound. It's a small machine only, sonocyte machine. We'll see now in the slides. So regularly we do with the small machine only. Slowly we have started doing functioning, because anyway in private practice you may not get that many number of stones due to PCNL. So what we have started, we used to do every ultrasound for every patient, not only for the PCNL patient, for URSL patient, RIRS patient, any patient, whoever comes into the OT, we regularly do ultrasound for the patient at the same time before starting the procedure. So we used to have anatomical orientation like that. And even when we are doing RIRS, we have done one study also for our student to puncture the kidney during RIRS, so that the system will drain completely and the image will clear nicely. And the chance of many patients are getting fever initially when we are doing RIRS, especially during summertime. So all the patient we have started doing puncture with small needle, that is lumbar puncture needle. Why I have selected lumbar puncture means you need not to have any 11 number blade to puncture the needle skin. It easily goes in, and the marking of the needle also won't be seen. Even sometimes what happens if you do some multiple punctures, and then multiple scars are there. It is annoying for the patient, and we have to explain why you have done all these things. So we have started doing with LP needle, so which won't be visible, just like a spinal anesthesia, and that is also 20 gauge needle, not the 18 gauge needle. So slowly we have started doing. Almost we have done till now more than 500 to 600 punctures we have done for all the patients, whether it is RARS, whether it is PCNL or URSL, because we are seeing the image properly and we are confident enough that we are not going to injure any structures, and at the same time we are puncturing the calyx properly, and at the same time it is helping us draining the system also. Slowly we are regularly doing. All the patients will put in supine position, and typically that supine lithotomy position where we are do typical for RIRS supine PCNL position only. Even if you do RIRS, the position will be supine PCNL position only. I will show that position also, what we regularly use for supine PCNL.
Yes, sir. You can start your presentation, sir.
Okay. Okay, ma, is it seen?
Yes, sir. Your slides are seen.
Okay. So as I told, you may not be able to see my image because I'm using the iPad.
Okay, sir.
So as I told my story, how I have started doing puncturing ultrasound. Whatever the procedure you want to learn, whatever you want to do something in your life, you will get some obstacles. Like as we know, there are three types of obstacles in learning or doing work. What we call regularly as sattvic, rajasic, and tamasic obstacles. You can see this image. When Lord Hanuman started jumping from India to Sri Lanka, he has got obstacles during when we are search for Sita. So the first obstacle is that is sattvic obstacle. That is, he is a friend of you only, but he will stop you to working. So you have to get rid of this problem also. Second one is rajasic atank, which is when you go that when you feel that you are superior, some obstacle will come which will stop you from doing work. So you should not feel that you are the superior one, you can achieve anything without any assistance from others. So you should come out of that obstacle also. The third part is tamasic, which we routinely come across. That is, tamasic is nothing but laziness, not able to progress, just being idle like that. So you should come out of all these three obstacles, then only we can progress in life. Just want to tell, because these presentation will be heard by many DNP students of mine and sir and everyone. So I just want to just explain them that these are the types of obstacles which we come across when we go for any procedure or any learning process or in our life. Similarly, when we want to start learning ultrasound to puncture, we'll also get some obstructions. What are the obstructions? Why should we learn ultrasound? We are very much 100% perfect in PCNL puncture. We have CM everywhere. Everything is there. Why should we learn? That is the first part, it will stop you from learning. Then, even though you want to learn, you should know the source from where we have to learn. So, as we know that this pure education program, before pure, after pure, there is a lot of change was there in urology, especially. Everyone knows. If you want to do something, learn in anything in urology, you can just go to the site of Pure Urology and just type it. You will get all the information. Tomorrow, if you go and if you want to learn ultrasound guided puncture, you can get Pure and go, just type it that ultrasound guided puncture. Then it will come. So everything will be available there. That is the source of learning. Now it has become very easy for us. Then third thing is make it practical. Though you have a lot of knowledge theoretically, if you cannot put that into practical thing, also very much difficult. Then you will stop there itself. So today we are going to learn ultrasound guided puncture. What are the ultrasound? What is the position of the patient? And what are the instruments we use for that? And what is the knowledge? How to do the technique? So first, ultrasound probe. Regularly, we have everyone will have this ultrasound. Even if you don't have ultrasound at your OT, it will be available in your radiologist suite. You can request the radiologist so that they can ship the ultrasound machine to the OT during the procedure. So everyone should know how to operate the ultrasound. This is the ultrasound machine what we regularly use. So it is like a cell phone or it is like a laptop only. You will have all the features in that one, how to on and off, zoom option, color Doppler option, just goes on reading that options, goes on trial and error, so that you can switch off, switch on the, so that you slowly learn, just like similar to like a phone, you learn. So these are the probes which will be regularly seen. What we regularly use is curvilinear probe because it is our structures, kidney and all these structures are deep structures. For superficial structures, when you want to see veins, vessels, penile Doppler, scrotum, you use usually linear Doppler, but linear probe. For user, especially for doing kidney puncture, we regularly use curvilinear, which the frequency of the probe is approximately 3.5 to 5. Then once you on the machine, once you have a probe in your hand, you should learn what are the movements of the probe so that you can see the image. First of all, you have to see the kidney image properly, which is cortex, which is pyramid, what we have to see. So for that, you know where we have to put the probe, whether it is in the anterior scapular line, mid scapular line, posterior axial line. You have to keep the ultrasound and do the movements in a way that you will see the kidney image properly. So that you can see the calyces, you can see the pelvis, you can see the cortex, medulla, and everything. So what are the movements like sliding movement, tilting movement, rotation movement, rocking movement? Whatever you do, all the type of movements, the ultimate target is you have to see the kidney image properly. I always use it to say that if you an anesthetist want to intubate a patient, first of all you should see the vocal cord properly. Then only you should hold the tube and then insert it. Similarly, when you want to puncture a kidney, you must see the kidney image properly, and at the same time you have to identify the surrounding organs like liver, spleen, small bowel, large bowel, like that. Then only you take the needle and start doing puncturing. So you should know about the your machine, you should know the probe what you are using, you should know the movements of the probe so that you can have a good image of this one. So this is the position. Next comes the position of the patient. What we regularly use, whether you do URSL, whether you do RARS, whether you do supine PCNL, for all our patients, the position is same. Supine PCNL position. This is the typical position where the hand of the ipsilateral side will be onto the chest, and we'll put a small pillow on the just lower part of the chest. Then the side of the surgery limb will be straight and the opposite side of the limb will be a bit elevated. So that simultaneously one surgeon can do procedure from down, the other person can do the puncture. This is the first case I want to just show you. You can just see the video. Are you able to see the video, Sandri?
We are able to see the video, sir.
Okay. So just see the what I am doing. Just I am moving the probe like what I have told you the images. In and out, rock and roll. Then see the image. The first part is you have to see the kidney properly first of all. So once you have seen the image, you can see the rectangular shape where you are seeing the kidney image. That is important. Just I want to stop here. So put the probe, see the image where you have to puncture, especially you have to see the calyx, pelvis, in a line, in line. Then mark the rectangle shape, what I have shown just in the video. Then you have to put your needle exactly in the middle of that rectangular shape. That will guide you to the same area puncture. Are you able to see the needle movement? You are able to see clearly the image. Now you are facing the cortex and slowly you will go inside. So we have not put any guide. There is no any guidance for us. The guidance is then start the urine slowly. Initially it may come blood. You have to push some saline from the down. Then even if you have any doubt that whether you have punctured properly or not, you can use diluted contrast. See this image. After puncture, you can see clearly see the calyces, that long infundibulum calyces are anterior calyces, and round calyx, what you are able to see is the posterior calyx. Then we have given contrast, which has been seen image properly. Total system is clearly delineated. This is the posterior calyx, lower, middle, and upper calyces. The other calyces are anterior calyces. So we have not done puncture with CM guidance. We have done puncture with ultrasound. Then we have given the contrast. We have ensured that we are in the properly aligned calyceal puncture. There's the same thing what we are seeing, the needle movement, which is entering into the calyx. Okay. This is the second case where you can see the positioning of the patient. So this is the typical position what we regularly use. Whether do URSL, whether do you RARS, whether you do PCNL, supine PCNL. Ultrasound on the same side of the patient and modified lithotomy position for the supine PCNL. The ipsilateral hand will be on the chest. So for every patient, for every procedure, we'll put the procedure like this only. So that every time the ultrasound is available to do the puncture readily. This case you can see my assistant is doing the procedure simultaneously from the down. This is the posterior axial line we have marked. This is the costal cartilage we have marked. Just 1 minute, Amma. Sorry for the disturbance. Just you can see everything is written on the buttons to select, to freeze and everything. That you have to spend some time with the ultrasound so that you can know what are the functions, individual button functions, how to zoom it, how to enlarge the image, how to get proper window. All this will be seen once you go on playing with the ultrasound. Though in case we are using betadine without cover, you must use that cover for sterile precautions should be taken. Then what I have told you, the movements of the probe, you just rock the movement, rotation of the movement, compression of the ultrasound. Whatever you do the image movements, you should see the proper image of the kidney. Then you have to identify the rectangle shape of the image where you are getting proper image. So this image we are seeing, and exactly at the center of that rectangular shape, we have to put the needle. This is 20 gauge LP needle. Exactly. If you want to puncture lower calyx, put the needle at the lower end of the rectangle. If you want to puncture at the middle calyx, you have to put in the middle of that rectangle. Then movement of the needle, as we do in the fluoro-guided puncture, craniocaudal adjustment, mediolateral adjustment, what we do, we have to also do similarly so that you can see the track of the needle. This is called inline puncture. In this one, you have to see the total length of the needle from the skin to the kidney surface. Not that you are able to see only part of the needle, that is not correct. If you see only part of the needle, you may go deep or you may be superficial. Can you see clearly that needle is seen, the tip of the needle is seen? And especially that LP needle, the tip will be very bright and it will be very echogenic. You can see clearly, especially once you cross the parenchyma, the tip of the needle will be seen very clearly. Can you see total length of the needle is visible?
Yes, sir.
And you can see bowel down and liver above. So that there will have a small window where you can go safely enter into the kidney without having any problem. So this is one more case. Same principle, whatever you do, whether it is right side, whether it is left side, whether it is dilated system, undilated system, the technique is same. You have to know the probe, you have to move the probe, then identify a rectangle shape where you can see the calyces, kidney and pelvis image in a single frame. That is very much important. And at the same time, you have to see the total needle track. This image is actually inverted. You can see the needle is moving.
Oh, yes, sir.
Actually, this recording is done wrongly. Sorry for that. Even you can do supracostal punctures also. Can you see the rib here? You are having a shadow.
Yes, sir. You can see the shadow.
Yes, that is rib shadow, is the post-acoustic shadow because of rib shadow. If you want to puncture below the coastal cartilage, now we are saying below coastal. This is the below infracoastal puncture. It is. Even if you can do supracostal puncture also, because you are able to see the rib, and at the same time you will check pleura also, whether you are going transpleurally also you can see. Can you able to see clearly? Once you enter the parenchyma, you can see clearly, and you are entering the now calyx. Now enter the calyx. So it is seeing is believing, because you are seeing and doing the puncture. You are not worried about at all that you are going to injuring structures. So clear urine is coming, and always I use 20 gauge needle, and always I use 0.25 guide wire instead of 0.32 and big needle, because 0.25 guide wire, what I feel is it is a bit stiff. So the dilatation also it is very easy. So when we are pushing, the clear urine is coming. And we have given contrast also in this patient. Can you able to see clearly the puncture through the posterior calyx? There is no extravasation of the contrast. Clearly see needle puncture and scope from down. This is one more case. You can see the movement of the tip of the needle clearly. There is no structures in between. You can clearly see the bowel shadow. You can see the liver, so that you can avoid the structures. Usually bowels looks like the dirty shadow, multiple dirty acoustic shadow with irregular dirty shadow. It will be seen. The colon will be looks like that. And especially in supine PCNL position, when you put the probe posteriorly, most of the times the bowel won't come in your way. This is one more case. This is a grossly dilated pelvis. You can able to see the image. In a single frame, you have to see the calyx and pelvis. You can inject saline from down instead of contrast, because saline itself is a will clearly seen in the ultrasound, unlike contrast. So this case we have done middle calyx puncture. You can see the movements of the turbid tissue. You can see the clear flow of the urine. So many times in ultrasound, your puncture may be more anterior also. This one case you can see from down with RIRS from where you have come also. So the needle movement, the LP needle you can see clearly coming through the papilla. So you are sure enough that in this situation, you are in the system and you can proceed with your dilatation. Okay, I think I have completed my videos.
Shall we discuss a few points?
Yes. Yes, yes.
So what is the cost of the machine that you are using, sir?
This machine is around 8 lakhs. Sonosite. Exact cost also I don't know actually.
Okay, sir. So sometimes whenever we use the ultrasound probe, we have certain difficulties like to firmly grip the probe. We may see very nice vision, dilated system beautifully with the ultrasound probe. But when it comes to puncture, keeping the same vision, because there may be hindrance because of the respiratory movements, or our
Yes.
probe slip when we keep the jelly, and when we puncture the skin, it will start bleeding. In that case, you have to wipe or mop it out. So the jelly will also be wiped out. Therefore, the interference between the probe and the skin, that coupling agent will be lost. Therefore, the
Yes.
skin will not be clear. So how do you overcome these difficulties? And how do you visualize the system? How do you keep the needle exactly in the proper direction which you wanted to keep? So how do you overcome these difficulties, sir?
The only thing is what we have done in this case regularly. What we are doing is we are using betadine solution directly. One is one way, but that will sometimes it may damage probe also. Instead of that, you can put jelly with on that one. You can put gloves. Then you can use betadine outside. You can put jelly in the glove and put the probe into that glove. Then dip that probe along with the glove in the betadine. Then use betadine. Usually won't be slippery. If you use jelly, the probe will slip and you have to wipe it out. It is difficult. Betadine solution is the best one. It has a good window. You can use sterilium spirit also, but usually directly using sterilium will damage the probe. So instead of that, you can put xylocaine jelly, which is a sterile one. Put the glove on that one. Then dip this probe into the betadine solution. Always you have to keep one small bowl of kidney tray or small bowl with full of betadine. You can put one small gauze piece in also that. Otherwise, you can put the probe and with syringe, you can take betadine solution and probe on the skin. Pour the betadine on the skin also. It will couple that it will avoid the loss of window.
So when you use the probe with a free hand, when you pass the needle, do you keep at one end of the probe to see the entire length of the needle, or do you pass the needle from the center of the probe? If you keep this needle from the center of the probe, the initial part where it punctures the skin may not be visible. So which is your preference, sir?
We have to do inline puncture only. Your needle should be always on the lower end of the probe only. You have to move the probe. If you want to do middle calyx puncture, move the probe more upwards, and always the needle comes from the lower end of the probe only. You cannot put in the middle of the probe. That rectangle shape, what I have told you, it is always important for me because 99% will be successful if you properly mark that rectangle shape with the betadine. And you put once you remove the probe, you see that shape. Put the needle exactly in the center of the one. If you want to puncture lower calyx, put on the lower end of the probe, that rectangle shape. If you want to puncture middle calyx, put the needle at the middle of that rectangular shape. Then again, once you have put the needle, then put probe again over the needle and see the image. You can clearly see the puncture line.
So do you do only punctures with the ultrasound guidance, or have you also attempted dilatation under ultrasound guidance?
No, only puncture, up to part of puncture only, because dilatation part, it may not be clearly visible. You may miss the track always. So only up to puncture and give the contrast, and up to after putting guide wire, most of the times we'll use it with the CM guidance only dilatation.
Do you find any difficulty between the right hand side puncture and the right kidney puncture and left kidney?
Definitely it will be difficult, but once you goes on doing more number of cases, it will be easy.
So for the left renal puncture, do you use the probe with the right hand and puncture with the left hand?
Yes. We have to both. We are able to puncture with both hands. You should be able to puncture with both hands, right hand, left hand. When you are sitting on the right hand, your probe will be on the left hand. When you are sitting on the left side of the patient, you will be probing on your right hand. So your needle holding needle hand will change, right hand, left hand.
So in obese patients with the lot of fat in the abdomen, so will the length of the LP needle be sufficient, or do you use any other needles in that case?
That will be difficult. Usually the length of the needle is not fine. And now we are getting more extra length needles also, especially spinal needles also. Extra 15 centimeters length needles also available. You can order for that also. For obese patient, even anesthetists will use long length needles for spinal anesthesia. Even sometimes spinal anesthesia will be difficult with the needle. They have an extra needle which has a long length also, 15 centimeters length.
Do you do these ultrasound guided punctures under GA or spinal anesthesia? So how do you control the respiratory movements by?
Most of the time, unless we are doing for an emergency case, we'll do local cases like pyonephrosis, infected hydronephrosis, empysematous pyelonephritis. We'll do usually under local anesthesia. For a patient who are the sick, that time it will be difficult because of respiratory movement. Otherwise, most of the times, all my punctures, all my procedures under general anesthesia only. Because anyway, we are doing RARS. We are doing supine PCNL, all under general anesthesia only. Because in supine position, putting tube, remote tube will be very easy. In prone position only, many of the times, because of anesthesia problem, they are doing under spinal anesthesia. For all cases, most of the times, we'll be comfortable with general anesthesia only. Because we'll ask the anesthetist, make them apneic for till the time of our puncture and dilatation also, so that you won't miss the track.
Sir, Dr. Harshavardhan has asked, is there any difference between the normal needle and the echo tip needle?
No, definitely. That ecotypical needle will have some small serrations, so it makes it is more visible. But what I felt is, I don't know what is their material in the LP needle, but it is will be clearly seen. Even our what PCN needle which we are using, usually it is not that much clearly seen. But LP needle, 100% it will be seeing total length. Maybe the density of the material in the LP needle, what they use may be different. That's why it is clearly seen. Most of the times, spinal blocks also they will give with this needle only, like axillary block, femoral block, what anesthetists regularly use, they will see the clearly needle. Then I thought, why should not we use this needle for our puncture also?
So what specific settings you use, like frequency, depth, or any what ultrasound settings you use before you start puncturing?
This routine ultrasound 3 point, the curvilinear probe, the frequency will be around 3.5 to 5 hertz only. That ultrasound probe only we use. We won't change any frequencies of the probe. The probe will have a fixed frequency. With that only regularly we use it. Especially the curvilinear probe, if the angle of that probe it is more curved, it is difficult to puncture. Always, if it is linear or minimal curvature of the probe, will make the needle very easy to identify. If the probe is, some ultrasound machines will have there is acute curve like this. That time you may miss the track also. It is very difficult to identify the center point for that. In that situations, we need guide. For this freehand puncture, though it is a curvilinear probe, the curvature should be a bit less, so that it will be very easy to identify where to put the needle.
So one more question is there, sir. Like, is there any tip to identify the anterior or the posterior calyx on ultrasound?
Definitely, if the probe slowly, once you have painted the area of the kidney, when you slowly move, your lower end of the probe should be always anterior, and the upper end will be posterior, because the kidney structure will be like that. Lower pole will be more anterior, upper pole will be more posterior. So your probe also should be in similar. I'm talking about supine PCNL position. So when the probe lower end is towards the lower pole of the kidney, slowly move the probe from the anterior to posterior, from anterior axillary line, from mid axillary line, from posterior axillary line. You will see the same image of calyx pelvis. If you are able to see a image in the anterior axillary line, the calyx and pelvis, most of the times it will be the anterior calyx. When you move the probe more and more posteriorly, you will see the same image of calyx and pelvis. That is posterior calyx.
So I think already you have covered, and one person has asked like where exactly to put the probe. Can you please explain once again, sir, for the benefit?
Can we go to that video again?
Yes, sir. You can share your screen, sir.
Stop sharing. Again, I have to share. Able to see this image?
Yes, sir. We are able to see the video running.
Okay. So you can see what I am marking, that is a posterior axial line, subcostal margin. We have already marked before. Then put the kidney probe in a way that the lower pole will be, lower end of the probe should be more anterior. Paint that area of the kidney nicely. Then you see how I am holding the probe. So you are seeing an image. See, that lower end of the probe is seeing more anterior. The upper end of the probe is more posterior. Then move the probe anteriorly, posteriorly. You tilt the probe, rock and roll, all the movements you do, whatever the movements you are comfortable. Like in RARS, when you start learning initially, whether to you are to pronate, whether to you supinate, you will think multiple times to see medial side, to see lateral side. You will do trial and error technique. When you do trial and error technique, slowly your brain will catch. If you do this movement, you will see this part. If you do move this movement, after a period of time doing more number of cases, there is no need to think about things. You will do it at your spinal level. So that's why you have to do ultrasound every time for every case. You can see that marking, rectangular shape, I am marking with the needle. That rectangle shape is very much important for freehand puncture, what I feel. because what you are seen image in this, that is the rectangle only, and your kidney is there in this rectangle only. So where you want to puncture, whether it is lower, middle or upper, you have to put the needle in the same area. Then once you go in needle, then you have to do two types of movement. One is move the needle lower end of the side, upper end of the side, so that you can reach middle or lower calyx. Then move the needle toward the ceiling, toward the floor. So this is called mediolateral craniocaudal adjustment, as like in CM. The ultimate goal is to see the total length of the needle from the skin to the calyx. Once you are not seeing clearly, then move the needle a bit cranial or caudal so that you can clearly see the needle totally. Okay, that now you are, once you enter the parenchyma, you will see more clearly the needle. I think I have explained clearly?
Yes,
Still
sir,
any
you have
doubt?
explained clearly. So the idea is to put the probe in between the 12th rib and the iliac crest, with the cranial end of the probe slightly posterior, with the
Yes.
caudal end of the probe slightly anterior, so that it exactly falls in line with the axis of the kidney, longitudinal axis of the kidney, which is 30 degrees anterior.
Yes, correct.
We'll be able to visualize the both upper, middle, and lower calyces in one line.
In one line, along with the calyx image and along with the pelvis image.
And the pelvis. Okay, sir. And one person has asked, like, are you able to see the dilators in the ultrasound, or what is your view on that?
Sorry, can you repeat the question?
Dilatation during PCNL under ultrasound guidance. Have you seen the dilators, or what is your view on it?
During dilatation, kidney dilatation or dilators, what they are saying?
Yes, sir. Dilatation during PCNL after the puncture.
After the puncture, okay. Now you can see once you put the image same direction where you have put the needle, you have to put the probe same way and slowly start dilating with the same one. You can do it, but many of the times when you dilate, you use both hands. Slowly screwing movement. So you are not able to hold the probe. Someone other person has to hold, because many of the times when you are doing puncturing, your left hand will be needle, right hand will be probe. But when you start doing dilatation, you cannot do dilate with single hand. You have to catch with left hand and right hand. So during dilatation, some other person has to show the image. That is the problem.
Yes, sir. True. So
any questions? Anything else?
Yes, sir. You have discussed in detail almost, and we have come to the end of the session. So thank you very much, sir. You have elaborated very nicely the true need of.
I just want to tell only 1 or 2, 3 points so that every person, it should be reproducible for any young urologist to do the puncture without any problem. Because many times what we see, if you are unable to puncture, we will refer that case to other person like radiologist and other person. So that should not be happen to urologists. So every urologist should be able to do kidney puncture without having any help from others. That is my target.
Yes, sir. Your presentation was very useful, sir. And the message is also well conveyed that this ultrasound is a very important part of any urologist armamentarium. And we need not go for high-end models with inbuilt trajectory and all that. That is the idea behind today's presentation, that even with freehand, safe ultrasound-guided puncture can be done. So colon can be avoided, viscera can be avoided in situations where we cannot come out, like fluoroscopy cannot be used, ureteric strictures or pregnant patients. So ultrasound guided puncture, one should have a clear knowledge of it. And there is no excuse that it is costly, it is not available and all that, because we have, economic low cost machines which are available, which are easily portable. So even without trajectory, how to use ultrasound is very well explained in today's session. So thank you so much, sir, for your cut explanation of all the points covered well.
Many times that person peripherally, when we go periphery for practice, stuck Foley balloon also they will call you. So they will do lot of procedures from down. They are unable to remove the Foley's catheter, and they will call you. If you don't know how to remove that catheter, it's very difficult. So you have to know the ultrasound, and you can do puncture from above just simply then and there itself. Because many of the gynecologists, general surgeons will have ultrasound their hospital. They will call you for stuck Foley balloon which is not coming out. Then you can go put your ultrasound, just puncture the balloon from above. Simply you will remove it. So they will appreciate you that your technique very nicely, and you will get definitely you will get more number of cases from them. So that is very important point where you have to puncture the balloon also, and you have to remove the Foley's catheter. Then only your superiority will be seen there. Otherwise, it is very difficult for us to see ourselves as a specialist.
Yes, sir. True, sir. So thank you so much, sir, for the nice session.
Thank you, ma. Thank you.
We hope to
Thank you for
learn a
inviting
lot
me.
more from you in future. Thank you, sir.
Thank you, ma. Thank you.